This webinar was co-sponsored by the Health Workforce Technical Assistance Center and the Center for Interdisciplinary Health Workforce Studies at Montana State University. And it is entitled Best Practices for State-Level Nursing Data Collection. And it was presented by Mary Lou Brunell, Elizabeth Carter, and Peter Buerhaus on January 24th, 2017.
Hello, my name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. And today's presentation focuses on best practices for state-level nursing data collection. But before we get started, I'd like to introduce today's speakers. Today's presenters are Mary Lou Brunell, the Executive Director of the Florida Center for Nursing, and Elizabeth Carter, the Director of the Virginia Department of Health Professions Healthcare Workforce Data Center. And we are also joined today by Peter Buerhaus, the Director of the Montana State University Center for Interdisciplinary Health Workforce Studies. And Peter will provide commentary on today's presentations. Now, at this point in time, I'm going to go ahead and turn the event over to our presenters. After the presentations, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the event ends, you'll be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. We would greatly appreciate it. Mary Lou?
Thank you, David.
You're welcome.
Good afternoon, everyone. I'm very pleased to be here with you and present some information about the Florida Center for Nursing. I'm going to just give an overview of the center and provide some of the information about how and why we were established and what we've accomplished. The Center for Nursing, I think I can change, there we go. The Center for Nursing actually was established through a collaborative effort of the Florida Nurses Association, Florida Organization of Nurse Executives, the nursing representative from the Florida Hospital Association, and various deans and directors from around the state. We were modeled after the North Carolina Center for Nursing and established in law. Our purpose is to address issues related to nursing manpower in our state. And our obligation is, as a state entity, to the people of Florida. Our vision is to be the definitive source of information, research, and strategies, addressing the dynamic nurse workforce needs in Florida. And we're fortunate to be housed at the University of Central Florida in Orlando. We work together information about supply, demand, and the education of nurses in the state. Our supply data, we began collecting supply data in 2003, when at my request, we received a complete data set of all licensed registered nurses in the state of Florida. What was obvious from our preliminary analysis was that there was a significant gap between those who are licensees versus those who are actually the nurse workforce. And we saw that the data set really contained excellent regulatory information, but really did not contain workforce data. So after that, we were able to collaborate with the Board of Nursing, and in 2004, the board agreed to send out a notice with the packets that were sent for license renewal. And so we were, through that means, requested nurses to come to an online site and to participate in a survey. In 2007, we actually were able to insert our nurse workforce survey within the online license renewal system. The state of Florida went to an online renewal system at the same time, and so we had contact, at least the opportunity for participation by the full nurse licensure data set. And in 2009, we actually updated the questions that we were asking and the survey items so that they reflected the 2009 minimum nurse supply data set as had been established through the National Forum of State Nursing Workforce Centers. So for every 2 years since then, we have completed analysis and produced reports about the supply of nurses in the state of Florida. And we're very pleased that since we've been incorporated into the online renewal, even though it is a voluntary process, we have greater than a 90% participation. We continue to show that gap between licensees and nursing workforce. However, what we're able to say now is what it means. And so when we look at the full licensed data set of full licensed data of all registered nurses in the state of Florida, we see that there's over 300,000 licensed nurses. But as we begin to clean that and look at the relevant data sets that are within that larger data set, we find that there are actually 102,000 plus registered nurse licensees, neither living nor working in the state of Florida. So we come down to the workable numbers of around 200,000. It just helps to demonstrate the value of someone looking at the data that is collected from a workforce perspective as opposed to a regulatory. The 300,000 number for the licensees is extremely important to the Board of Nursing. Our demand data continues to be a paper survey system. We began surveying 5 industry groups and expanded that to add a 6th industry group in 2009. Our very first survey in 2000 was a 37.3% return rate overall. Obviously, it was higher in some industries and lower in some others, but we were actually fairly pleased with that. Unfortunately, over time, we've actually seen our response rates dwindle. So though we still receive 20% participation rate overall and very good participation rate from public health departments, and even our hospitals provide a pretty good participation rate, we're still concerned in looking at options and opportunities as to how we might be able to improve the surveying for demand data collection. We do know that on our last survey, which was in 2015, and this one is also conducted every 2 years, we knew that from our data collection there were nearly 12,500 vacancies in Florida, and that the participating industries projected an increase in positions, not just vacant, but actually adding of new positions of nearly 10,000. So we're still were able to document a shortage of over 22,000 registered nurses in the state of Florida. We also gather relevant information about the difficult-to-fill positions. And what that has been consistently showing is the desire by employers for individuals and nurses with higher education and or more experience. Our education data is collected also through an electronic model. We do collect this on an annual basis, and we collect it by sending, we establish and create a list of all emails for deans and directors throughout the state of Florida. We did our first effort in 2007, at which time we received 140 out of the 149 pre-licensure LPN and RN program surveys were returned for a 94% response rate. Very pleased with that, obviously. As has been the case in the state of Florida, there's been some changes in the regulation of our education programs. As a result of those changes, we've seen a significant increase in the number of programs in the state, so that in 2016, we had to survey 326 programs, and you have the breakdown on the slide of how many per education level. We had a greater than 50% participation rate, but we're actually reporting results based on the state programs versus all programs. Our interest there is trying to help support the need in the state of Florida that is going forward this year through the legislation to reinstate some of the regulatory rules that the Board of Nursing would have related to overseeing the education programs in our state. We do, by the way, through the education data collection, also collect information about faculty shortages. Center funding we were initially a line item in the state budget after we were first established until 2010, and then we did have some funding in 2015. Our donations that we received from nurses and nursing organizations equal about $35,000 a year. And we've really been dependent and extremely grateful for the grants received from the Florida Blue Foundation. That is really how we've been able to continue our core research work even during those times that we are not receiving state funding. We do receive a lot of in-kind contributions from the University of Central Florida. We receive our space so we don't have to pay rent. They provide us human resource and fiscal services, and we receive our IT support from the university. Also, we're able to purchase within the state system, so we receive discounts on items that we need to purchase that would not otherwise be available to us. We have felt it important to demonstrate our value, and we feel that the state has really acknowledged, and by the state, I think users of our data have truly acknowledged the quality of our data reported. Our ability to provide trends and forecasts is seen as extremely important. Our information is published at a statewide and regional levels, and we provide testimony for the Florida legislature on request. I'll be going up in February to testify to the House of Representatives Quality Healthcare Committee. Our data is utilized by legislators and staff to justify proposals. We also, through our available data being available to the public, know that it's extensively used in grant applications and to provide justification for new programs and or program growth. We did a survey for 3 months a couple of years ago of who's using our website and for what purposes. And we were very surprised, in a positive way, to find we had a high use of our survey and data reports by venture capitalists for the state, including those from other countries. We have certainly faced some challenges. In the early years, we had to work to be certain that everyone understood the difference between the Florida Center for Nursing and other nursing programs and groups, such as the Florida Nurses Association. We also had to work to build state agency cooperation and the building of trust among the various groups whom we wanted to collaborate and partner with. We continue to have some funding challenges, and we also continue to try to improve especially our demand survey response rates. We are optimistic as far as our education response rates improving, because there is currently a bill going through the Senate, and there will be a companion bill in the House that would actually mandate that education programs participate and provide data to the Center for Nursing. So we're very hopeful that that bill will pass with that language. And we also, as a Center for Nursing, residing in the University of Central Florida, have had some challenges of fitting into an academic model. Our opportunities that we've held is really the ability to make a difference. We see that our data has been used and is important and is valued. We do feel that we influence policy, and sometimes it's not necessarily the policy that we might promote, but nonetheless it's policy that the data has indicated or been used to indicate a need for. We have really succeeded with collaboration with state agencies, and we've developed a lot of programs around our work and brought in grant support for those programs. Our optimistic side is looking to expand, such as that we will be a workforce center for all health professions and occupations. So we are in discussions with the university to establish the Healthcare Workforce Research Institute of Florida, and that would comprise all, as I mentioned, health occupation data and information for the state of Florida. Again, I thank you for this opportunity, and I'd be glad to answer any questions as well as information about how you can see our reports and follow our work, or if you'd like to send something to me personally, there's the contact information. Thank you very much.
Thank you, Mary Lou. Elizabeth?
Thank you all for inviting me today to share with you what Virginia has been able to accomplish. I'll tell you first of all about the Virginia Department of Health Professions. We are the licensing entity for Virginia's over 60 health professions, well over 350,000 licensees. The structure that you see on the organizational chart kind of reflects the shared vision or the shared resources that are available for our 13 licensing boards, and that I cannot say how much that has really helped us to be able to systematize and replicate what we learned for each profession across multiple ones. If you look on that right-hand side toward the bottom, you'll see, in addition to the Board of Nursing, Pharmacy, Medicine, and so forth, there's a Board of Health Professions, and that is a body that is comprised of members from each of the licensing boards and 5 citizen members. And I'm the staff for that as well. I'm the executive director for the board. We share our research staff. I have a deputy director below me and an operations manager and a part-time economist who help us do all sorts of policy research. So that existed since about the 1970s forward. So we've had a long history of working together and also sharing resources from our HR, our finance, all of those kinds of things that already exist within the center. I'd like to give you, again, a little background as well. We actually had a mandate in the Department of Health Professions back in 2007. It was a concluding report from the then Governor Tim Kaine. He had created a commission. He was concerned about the growing and aging population in Virginia. We have a diverse population, and we're under a lot of change. At the same time, we knew that, just based on our licensure information, that we had practitioners that were beginning to age quite a bit, and particularly among the physicians and nurses, and even our long-term care delivery kinds of folks that work in nursing homes and so forth. And so there's a pressing concern that we needed to do something more. And so the very first recommendation out of that commission was the creation of the Healthcare Workforce Data Center within the Department of Health Professions. Again, we had online licensing renewal for many years. It was very easy for us, and of course Virginia, as I mentioned other times, we tend to be very frugal. We will go for the biggest bang for the buck whenever you can do that, and so it just made sense for us to be able to leverage what we had. In 2009, we actually got legislation, and it's very important, I think, for all the states or anyone else who's listening to this. You need to have the authority to collect that data in the first place, and we got that in 2009. It must be kept confidential, but we do have mechanisms to share de-identified data, and I'll show you a little bit later about the kinds of reports that we do as well, the other kinds of relationships that we have with some of the other state agencies, universities, and so forth. When we started, we had well over 100 stakeholders, and we asked for national consultants to help us, and I know at least one of those consultants is on the line. And we had to determine, first of all, because we kind of looked at, what was going on back in 2007. Yes, we knew there are different entities out there collecting data different ways. You had a lot of ad hoc studies. Everybody's methodology was a little bit different, and we were kind of just struggling through, like, where are the whole, and what data does the state already collect? You have employment data from one agency, you have, educational data in another, and it's just kind of on a little hole. And as Mary Lou pointed out, we found out definitely you can't rely on licensure data alone. We have, for our RNs, there's about 18% to 16% that are not in the workforce in any given year. And for our physicians, I'll tell you, our last report was 48% of our licensees, 48% did not practice in Virginia. So that's a significant thing to note. We were able to develop within this short time multiple profession-specific surveys launched through our online licensure renewal system, and we too also have picked up, the Board of Nursing had its own RN, LPN education surveys for a number of years prior to that, but we've taken on that analysis. Our mission, very straightforward, is to improve the data collection and measurement of our healthcare workforce, and as I mentioned before, there are over 60 professions. Actually, there's over close to 390 practitioners right now. And our data are provided online in a compiled fashion, and there's a mechanism that we have now with the Virginia Longitudinal Data System to share de-identified data to legitimate researchers through that system. By the end of 2012, we were fortunate enough to have enough different kinds of surveys developed for different professions, because we started with each profession independently. But we found so much similarities between them in terms of demographic information. We made references to whatever federal standards were out there to the degree we could. And by the December of 2012, we were able to standardize our methods so that an FTE, for example, a dentist may work 30-hour weeks and a nurse practitioner may work 45. But everybody is on a 2,000-hour per year metric. So that's how you determine your FTE. So that's been wonderful. And I won't belabor it here now because I know we don't have a lot of time to go into it, but we actually came up with a sort of a standardized glossary. What do we mean by all the terms that we use in all of our surveys? And so I'd urge anybody who's interested to look into that, and I'll be happy to talk with anybody offline later about our approach. You will have variations. I mentioned you have these care force factors, these systematized factors, but there are differences as well. But by and large, what I have listed on the slide here are what we call our care force factors. So the license and renewal statistics are the same for everyone. Those that are not, the percentage of those not working in Virginia are the same. Demographics, childhood, did you come from a rural background, an urban background? Did you go to school? Where did you go? Your level of your degree, your level of educational depth, your employment situation, which sector do you work in, work settings, work roles, when do you expect to retire? And these are all the same, and these were advised, again, with that original 100 stakeholder groups. We had the Employment Commission help us with this, and the folks that are interested in workforce. It's not just health, it's health workforce. So they helped us quite a bit into standardizing how we approached our surveys. These are, we call them data products, and if you check on that, the very first top line there, that is our main website. I have a little Tumblr site there that we display our interactive reports. I think those are extraordinarily important because we share our care force factors across professions, within professions over time, and within regions of the state. And we even have special reports that look at FTE at the county level. Again, we always preserve confidentiality, so we don't have an N size of less than 10. But you'll find from each of these reports a great deal of information. Our profession-specific report, and I'll show you quickly just what it looks like in just a moment, it really goes, it's the mainstay. Each profession that we do, as part of their license renewal process, they have a survey, and we analyze that survey because we systematize it. We can do it in about 2 weeks after the renewal period is over. And then we meet with the respective board and share the results, and then we post those results on our website. So we have basically a library that is available now for, it's up to 27. We're working on a 28th profession right now, so just wanted to share that with you. Those care force snapshots, those are interactive. Those are on the Tumblr site, and it's statewide overall for the Virginia Care Force snapshot. And then we have the regional ones are broken out by area health education centers. We're looking at other breakouts in the future, but right now we do have those. The reason why these breakouts are so important is that when you're writing grants, again, I think Mary mentioned, how important it is to use our data. It is very useful to different regions of the state to be able to note it's not just the number of licensees overall, it's the number of licensees that are working in our particular region that's very important. We also have a cute little tool. It's called Student Choice. We've been pulling a lot of federal data together with what our findings are as a tool for students who might be interested in nursing, in dentistry, and different things, just to understand what the level of education is required, the level of debt they may incur, the kind of salary. And one of the things that we have in our surveys are we look for your own satisfaction, your job satisfaction, and we tend to find within the health arena a very high level of job satisfaction. So we hope that bodes well for people to continue in their profession. So that kind of information is drawn out of our work as well. And on the demand side, that's part of our job is also the demand. We're a little bit weaker on that. We have relied, it's called the Health Workforce Brief. We tend to look at state and national employment data that relate to the healthcare and social assistance sector, so we don't break it down into individual professions. But we look at the Virginia regional sector employment, income and compensation. Some of those are quarterly and some of those are monthly reports. That's a listing right there of the surveys that we have, and as I indicated, more are planned. We do it as part of the license renewal. For some of the professions, they renew every year, all at one time, like within a month. Other professions, like nursing, renew by birth month because of their numbers. It's such a large group, and they do it every other year. So we do catchments every year because the folks that would renew in 2013 will renew in 2015. And then we have another group that will renew in 2014, and they renew also in 2016. We do annual reports for nursing that break that out, saying this is about half the population in one year and half the next. We've done, instead of waiting for 2 years to do it, because we felt like, and this may change in the future, but we felt, it's such an important profession to keep tracking to make sure that we're on top of changes that may be occurring. We did move to have that done on an annual basis. This is just to show you what the profession-specific reports are. The cover is there. There's a care force snapshot, just a visual. When we talk about those regional care force, you'll see, like on the left-hand side, we have it broken out by those particular area health education center regions. If you actually go and play on those sites, you'll get those tables will change when you select a particular region. So all those care force factors for those various professions are there. Some folks prefer to have those bubble charts, and so those are also available. Examples of other reports, as mentioned earlier, we also do the nursing education program report. So for each academic year, you'll see it, following that link, you'll see a report for both the RN and the LPN programs. We look at turnover rates for faculty, a lot of demographic information, attrition rates, those kinds of things, and we get a very, very high response rate on that as well. It's mandated, has been for many years for the Board of Nursing, so it's only about 2 or 3 that will not respond within a given time frame, and we end up having to go back and get their information, so we have a really good sense of that. We were also, the Board of Nursing asked us to also do a special report looking at, how we're progressing to the BSN level. Instead of, we do have a lot of folks that had associate's degree, maybe even diploma, but how that moves through the years, because we ask in our profession-specific survey, what was the level that you started and where are you now? And we also are tracking people that are in school right now. Just let us know how many are actually, what kind of degree you're pursuing. And as of the last report, we're at 56% that have a BSN or higher, and 10% of our RNs have, our nurse practitioners have a doctoral level. We were also asked by the General Assembly a few years back to do a Medicaid workforce packet, because we do ask for those practitioners that have a way to accept billing for themselves, who's accepting Medicaid. And we did a breakout for physicians, for nurse practitioners, and for PAs. So that information, it was a one-time study, but it gives you an example of what we've been asked to do by our government. Some other examples of our uses, we have what's called a Council on Virginia's Future. They're sort of the big strategic planning group that works with our General Assembly, our governors, to just look at, like, what's the health of Virginia? What does it look like for our workforce, particularly with health, and nursing information is used for their report on that. And they've been wonderful to work with. I know states are dealing with, many of them are dealing with the opioid crisis, and our data are actually used to assist a Health and Criminal Data Monitoring Council. Again, everything is confidential, but de-identified data can go a long way to helping you understand who can prescribe opioids in particular areas of the state. So we shared that with the folks over on the criminal justice side who can look at rates of death. There's a million things that will come out of this particular group, but we work with them as well. For the Virginia Department of Health, they're the ones who, for many years, and still do, they do the HPSAs, they do the shortage designations for our state. And so this is the first year where they've actually incorporated our data into their formula for reporting. They did that back in October, and I guess we'll hear pretty soon about whether or not that's been accepted. But because, as Mary Lou mentioned, you can't just rely on licensure data. You really must know about the workforce. We've been doing this enough to where we feel very confident that when we say whatever the percentage is in whatever particular area it is of people that are working there, that they use that information as opposed to trying to figure out something through just a survey by phone or just using licensure data. So that's been very important. We're also helping them on a number of grant proposals that they've been working on for the last about 6 months. I mentioned also the Virginia Longitudinal Data System. This is something that most states, and this will be through your education departments largely. There were grants from the Department of Education back in 2009 in many states where they're looking at education and workforce, sharing data across those kinds of agencies so that you could figure out your return on investment. Is it worth you're taking Algebra 2, for example, those kinds of things. And initially they only had the Employment Commission, K through 12, our Department of Education, our community college system, and our State Council on Higher Education. They were the original partners. They got together and they were actually able to develop a wonderful software capability and also a data governance thing. So when you're looking at sharing data across multiple state agencies, we are able to do that. We're able to maintain our own data. The system will double de-identify it so that I can't even go back and tell you the particular respondent, but it will merge data across agencies on individuals. And I know it sounds like Big Brother, but it really isn't. It's wonderful. If anybody's interested in that, I can do a whole separate webinar on that one. And then we also have the Health Workforce Development Authority. Back in 2010, Virginia was the only state to get a HRSA grant on workforce implementation. From that group really focuses on the pipeline side of things, but they use our data for their grant proposals and we work together very closely. This is our staff, and there's our contact information, and we're always happy to chat with anyone who's interested. Thank you.
Thank you, Elizabeth. And at this point in time, we'll turn over the event to Peter.
Hey, David, thanks very much. And I do want to say thank you for all your efforts to get this this particular webinar organized, and the two that will follow that I'm sure you will talk about as well. Also wanted to recognize Jean Moore, who's the director of the New York Center for Health Workforce Studies, her role in helping organize all this together. And Mary Lou, and it was good to hear your voice again. Thank you, Elizabeth. Good to meet you and hear about what's going on in Virginia. David, what I thought I would do is maybe just back up for a second and sort of put some of this webinar series and the presentations that we heard in context. And so what I'm thinking of is, you know, here we are in 2017, and we're moving forward to face, I think, some significant challenges that ultimately will require much better data and much better data at the state level on both supply and demand to help educators, employers, policymakers anticipate and prepare for these changes. And what I'm talking about is, first of all, the retirement of nearly 80 million baby boomers. They're not all going to come into Medicare at once, but they've already begun to enroll in the program. And we know that over age 65, that 3/4 of these individuals who will come into Medicare will have multiple chronic diseases, and many will have chronic degenerative diseases. This means that the demand for care, the demand for nursing will go up, and the complexity and intensity of nursing care required to manage these very complicated populations will require. That's 80 million people, and they'll be distributed unevenly across the country, but a large new growth in demand heading our way. Now that comes right up against physician shortages, and there are various estimates out there, but it appears that on the primary care side, between now and 2025, we could be down as many as 35,000 primary care physicians, and even larger numbers of specialists, up to 63,000, including surgeons. Now this means that more care is going to be shifted onto nurses, and particularly advanced practice nurses and others in our healthcare system. A third big element or challenge coming right on us now is the retirement of 1 million nurses, registered nurses, over the next 10 years. It's just begun, and we, if you want to sort of say it, you ain't seen nothing yet. The big surges are yet to come. And what that means is, yes, we'll have a loss in numbers, but we will have a loss in knowledge and education, skill, experience, as millions of years of nursing experience gets lost to the workforce. That's something that we need, I think, to pay particular attention to. We think at a national basis we'll be able to produce enough nurses to physically replace those that are retiring, but it's the knowledge and skills and experience that will be difficult to replace. So on top of our retirement of our baby boom generation, the physician shortages, the retirement of our own workforce, now we're beginning a new era of health reform, and it's way, way too early to really understand what will be the shape of those reforms, how they will impact the healthcare delivery and financing systems, and how, of course, they will affect the workforces. But I think it's safe to say that all of these big challenges will affect localities and regions and markets differently. They will have a different effect in different states, some being not so large or important. Others, it could be quite dramatic. So that means we need to rely less on national data and more on state data collections. So in listening to our presentations, I was delighted to hear and see on one of the slides that Mary Lou showed about Florida reaching into collecting data on the psychiatric hospitals, and so often those institutions are not included in data collection efforts. They also, in Florida, were looking at home health care, skilled nursing centers, which makes a lot of sense given Florida's unique population. And then I liked how Mary Lou showed that her center is working with at least 2 others, sharing information and working together. The efforts in Virginia, I thought, were important in that it reminded me of how important it is not to just be so nursing focused or centric, and there's nothing wrong with that. That's important as it is. But at the same time, we know that across the healthcare workforce, everybody's role, everybody's responsibilities are changing. As we've seen an emphasis on delivery reform, as we see now potentially a new effort on consumerism and getting choice and people back into the marketplace, perhaps developing. This means that each of our roles and responsibilities will change, and those are not necessarily easy to accomplish. So that supports my point about how good it is that Virginia has this broad approach to looking at the larger enterprise of the workforce. Now, Dave, what I thought I would do is just sort of throw out maybe two broad questions that either Mary Lou or Elizabeth might want to react to. But what occurred to me on the demand side, first of all, is that I think we all know collecting demand data is hard. And we tend to sort of go back to employers and we say, what is your thinking about the number of RNs or LPNs or other healthcare workers that you think you'll be hiring over the next year or 2 years or 3 years? And so my sort of questions are, and I appreciate Mary Lou's and Elizabeth's responses. First of all, are employers able to even sort of give you that information? Given all the changes that we've had recently, are they able to say, here's what we're going to do and this is what we think is going to happen? That's sort of part A. Then the second thing I'm wondering about is, have you either of you ever gone back to find out how accurate or how matched up were employers' estimates of the demand that they reported on the surveys than with what they actually did a year or two later? Were you able to go back and match that up to see how accurate that is? That's my concern on the demand side. And on the supply side, I'm hoping that in our states we will focus more on retirement data on the registered nurse workforce. And so I'm interested in hearing if you have found any questions that seem to do a very good job at accurately assessing the retirement behavior of registered nurses. David, I'll stop there and give you back the microphone. How's that?
Thank you, Peter. Mary Lou, Elizabeth, do you all have responses to his questions?
This is Mary Lou. I'd be happy to respond.
Great.
Okay. All right. Those are very good questions, Peter, and actually I think that the employer projection question, how accurate it is, we have not actually gone back and checked, so we can't say that we can validate, and in part that's because we do not necessarily have the same employers participating year after year on the survey. So you really can't do a direct comparison from one year to one survey period to the other survey period. I do feel fairly confident about the projections in that we could see changes in projections as Florida's economy was affected, so that when the economy was really in trouble here in our state and there was an absence of growth and, in fact, concern about how much would need to be done in the way of cutting and actually reducing the size of some of our healthcare systems, they would not answer that question. As the economy was recovering then over the next two, so 2013 and then 2015 data collection, we saw greater comfort and confidence in putting forward some of those projections. Knowing my colleagues in the health industry, I do know that they tend to project out to 2 to 5 years, not more than 5 certainly, and often not any more than 2. And we ask for simply the next year. So we don't ask them to project further than the following year in which we're doing the study. From the supply standpoint, as to what's used as the baseline projection within the modeling system for forecasting for retirement, as I recall, and David certainly would know this better than I, but I think it was available information about female academic retirements. I'm not sure. But so we don't have good retirement or movement out of, it's not even necessarily retirement, because I think there is another point where nurses are moving out of nursing, and it's earlier than retirement age, and it's due to the demands, physical and emotional, and hours of demand that are put upon them that they do not feel in their older, and as they're a little bit more than middle-aged, that they really want to continue to perform at that level or in that way. So there's another pocket, I think, that we have not identified that we need to look at, which is perhaps that 55 to 70, who still is working but perhaps not in nursing.
All right, and this is Elizabeth. I'd like to follow up as well. In terms of the employer projections, we don't survey them. We rely pretty much primarily on the federal data, but also data from our Virginia Employment Commission. They have something called an LMI, or a labor market information tool, and in any given week you can run analyses across the state by region, by sectors for various jobs to determine how many openings there are versus how many have applied for it. But again, it's all through the Employment Commission's piece. We know that is available. We haven't developed a methodology yet to standardize how often we look at that. But that's one approach that we might be considering. Another thing that we're looking at, as we started off with the supply side, trying to figure out how we would standardize how Virginia measures that, we're looking into, hopefully this year, putting together another stakeholder group of the folks who would know and how they would like us to standardize our measure of demand. We know that there are shortage designations already in the MUAs and the HWTACs for the oral health and primary care and behavioral health folks. But for those that are indeed employees as opposed to proprietors of their businesses, this is one way to get at it. So we're going to look to see how we can develop the policy within the next couple of years on that. With regard to the retirement data, we do collect it. Again, we ask on everybody basically, what are your plans within the next 2 years, the next 10 years, and then we do projections based on when we think about half of the workforce, of the current workforce would be retired. And we do that for all the professions. And so, like for example, about 7% of our RNs told us that they are intending to retire within 2 years. Within 10 years, about 25% again of the current ones, and then by 2041, half of our workforce, the existing workforce, will have retired. That's their plans. And we monitor this every year. We haven't pulled out a particular report for retirement, but we have the data there. So they can be done by someone who might be interested in it. And that's why we're available for the educational community and just anyone who's interested in the workforce. We're happy to help work with them to get data to answer some of those questions. So we are moving in that direction. Again, we've systematized. I'm happy to share our surveys with anybody who's interested to track it that way, because it does help. It does help us. We also look in terms of validating. Here's the other piece of it. We do check to see the drop in the workforce that is being projected. So, for example, we do about 7%. It indicated it about 2 years ago, and about 8% actually 2 years ago. The ones that responded 2 years ago dropped out. So I'm doing that in bits and pieces. It's just not systematized quite yet, but you can do it because the data exists.
All right, thank you. Peter, do you have another question for our panelists, or would you like me to jump in?
Go ahead and jump in, and I'm curious about the questions and the dialogue that will ensue.
Okay, thank you. Actually, this question once more is for both Mary Lou and Elizabeth. What would you do differently if you were initiating your center today?
Well, this is Mary Lou. I have had thoughts about, did we take the right approach at establishing the center as a state entity? And I do think we did. It affords us access to data and information that we would not otherwise have or may not otherwise have. So I think that's a positive thing. I think that what I might do differently is we exist as kind of this, just the Center for Nursing is its own entity. In other words, we don't report within another state agency. So nobody really kind of feels like they own us, if you will. That didn't stand out as an issue until we lost our funding. So, I think that I would look at how the structure is that the centers or workforce entity, how they are structured. Elizabeth's being structured within that system gives it, a voice from higher levels of government that I think is something that we're lacking.
Yes, ours was mandated. It was basically, you do this. So we were like, okay, yeah. We'll figure out how to do that. The only thing that I would say, we're challenged in that, as you saw on my last slide, the staff are relatively small. We have to do, there's a lot that we do to engage with the other agencies in partnership, but trying to figure out, you know, the bigger demand piece is going to be a challenge for us because you're talking to about half of the staff right now. So, you know, I think I'm going to build on what we have. We'll certainly do that, and so that our funding, thank goodness, we started off. We did get a Workforce Investment Act grant from the governor to give us sort of that initial boost. We were very fortunate that we had most of the stakeholders were volunteers. We didn't even have to pay them, which was lovely. You know, so that, you know, because everybody was so interested. This is such an issue of concern, you know, among folks that are in the hospital and healthcare systems, educational arena, you know, just everywhere. We found that we had a lot of good feelings about what we're doing, and I'm going to tap into that again. So we'll see, but our funding is relatively small. I mean, it's about $400,000 a year, and that's for both Board of Health Professions and Healthcare Workforce Data Center. So it works out to be about $1.15 a licensee, so nobody's fussing about it. But we can't do a whole lot more than what we're doing right now. We don't have a lot of money, for example, to go to a lot of conferences and things like that. I can do it on occasion, but there's so much more interconnection that we need, and I think I'm so thankful for the HWTAC being able to help us at least talk to each other. I mean, our community of people that are interested in workforce and health workforce is relatively small, and we don't really have a mechanism to talk to one another. So I think the information exchanges that we're doing now, it's going to make us all better.
Thank you both. Liz, you mentioned your funding level. What would your ideal annual funding level be? And Mary Lou, I would throw that one out to you as well.
I think mine is more in terms of how many FTE we can have. One of the things that I'm sure other states are like this as well. Agencies are only, even though the agency is self-funded, our General Assembly determines how many full-time equivalencies we have, how many positions we can have. And because we do so many other things, we do licensure, we do discipline, we do, you know, anything relating to public protection from a regulatory standpoint. That's our bailiwick. And the Healthcare Workforce Data Center is a smaller piece of all of that. So, you know, it'd be nice to have another couple of people, but I don't think that's going to happen right away unless I can find some grant funding or some other, even that, because I can get them as a consultant. I can do that, but I can't hire them as a state employee unless I get approval to do so. So that's a little bit of a challenge for us. So it's not so much the money as it is the ability to hire the folks that I might need here for ongoing research. I can use consultants, but I can't necessarily hire new people.
And ours here in Florida it's all about the money. We don't have any restrictions on how many people we can hire as long as I can pay for them. The university's in-kind contribution, space and so forth, allows us to truly maximize what we do with whatever funds we do receive. Our ideal funding level is in the area of $400,000 to $500,000 a year, and I say that range because as soon as we're at the $400,000 and then going over it, we start to be able to do some more special projects and not simply focus on our research agenda. So I'd say that if you just wanted us to do our supply, demand, education, data analysis, and reporting, and so forth, you know, you'd be looking at around the $400,000 mark a year. Although we work pretty conservatively as far as costs, and so I feel we're highly productive with what we do receive.
All right, thank you, Mary Lou and Elizabeth. I'll tell you what, I got one more question from both of you, and then Peter, if you have any closing thoughts, you know, by all means provide them. With that said, my final question for both of you, is there any like special software that you use that's needed for your reports you do, et cetera, for the data collection, what have you?
This is Mary Lou. I can't speak to that. There may be. Our data collection for the supply data is done through whatever system the Department of Health uses for license renewal. So there may be a system in particular or a software package that I just am not sure what it would be. From the other work that we do, we work with our Institute for Simulation and Training here at the university, and we have a server that they oversee for us, and they put together our surveys. We pay for their time and so forth. So again, I'm sure they use software, but I have to apologize. And I can, if someone wants to know that, I can try to find out and ask my colleagues who do that work if there is a particular software. I will say, for other than our data collection with supply and demand in education, for other surveys, we use Qualtrics, which is available to us from the university, in the university system, and it works very well.
And this, Elizabeth, we too have our online surveys are part of the license renewal process, and so the department staff here actually, they placed it within our system. So I don't know the details on that piece either. We get their information downloaded to us through just an Excel spreadsheet, and we then take that data and we use SPSS, but any statistical software package would be fine. I mean, you can do some of this work actually in Excel itself. In terms of our, when you get a chance to look at the reports, you'll see we use, I think they're rather attractive, so we use Python to make them look really nice, and we also, our interactive reports, we use Tableau, and right now we're using the public version of Tableau. I don't think you should be tied up on not having a particular kind of software. I think the biggest piece here is just to get the data collected in the first place. The other piece will come. You'll find a way to get your data analyzed, but you really do need to have the data collected.
All right. Thank you, Mary Lou and Liz. Peter, do you have any closing thoughts?
Thanks, David. Just a couple quick ones. I'm wondering, and just sort of thinking out loud, that as we gather more and more data at the state level, I think it's very important to find ways to bring the demanders and the suppliers together to understand the data, and then maybe to jointly work out ways to better refine future data collections. So I'm thinking about employers who are using nurses in different ways and have thoughts about how the value and productivity of a nurse might be changed or altered, and needing that information to be shared with educators so that educators who are supplying and producing nurses are better in touch with what are these big changes going on and what can be done in the educational space to increase the preparation of these nurses. Something to think about. Another thing that strikes me is that as we move into this new era of health reform, I think the media will be increasingly connected and concerned and interested in what is going to happen with healthcare in your state and your workforces. So it seems that our workforce centers need to be, I think, even better prepared to talk about the key assumptions, limitations of their data sets, of their data collection, and frankly, to have a much greater statements and clarification around what is the meaning of this data, what does that mean? Supply and demand data, and help the media understand what this is all about versus just giving them a sound pitch. So I'll leave it at there, David, and again, thank you very much.
Thank you, Peter. And as you mentioned previously, this is the first of a three-part webinar series. The next webinar is scheduled for February 22nd, and it will focus on using nursing workforce data to inform state policy. And then the third webinar in the series is scheduled for March 22nd, and it will focus on two states' experiences using HRSA's web-based nursing supply and demand model. And with that said, once more, thank you, Mary Lou, thank you, Elizabeth, and thank you, Peter, for being at our event, and thank you in the audience for attending this afternoon. I hope to see you all again in the future.
And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.